Okay, so what we're going to do today is we're going to back up and talk about terminology in chapter 2. And then we'll get into upper extremity. We'll probably go through wrist. We might get forearm, but probably won't get past that. So we'll take a break at the break, we'll skip chapter 4, chapter 5. So skeletal divisions, that was in chapter 2. And we've got the appendicular skeleton, which is what we're going to be focusing on now until we get up to the pelvis, and then we've got the or into the spine rather, and then we've got the exoskeleton. So general bony features, we've got an outer portion of the bone, it's called compact bone. A lot of times it's referred to as the cortical bone, the cortex of something being the outer portion of something. And that's where the strength in the bone is. So whenever you look at an x-ray of the bones, mainly what you're seeing there is going to be the outer portion of the bone, the cortical bone. So it's a strong, dense outer layer, and it's a varying thickness depending on the health of the bone. So your osteoporotic patients, in a lot of cases, or not really in a lot of cases, in all cases, what you're going to see is a thinning of that cortical bone. And then on the inside, you've got the spongy bone, and that's less dense, and it's kind of a spider web appearance to the bone itself. So if you're looking at extremity work, all those little lines that you see going through the inner canal is your what we call cancellous bone. So your trabecula, inside of the bone, the marrow cavity inside of the bone contains both red and yellow marrow. And you've got significantly more red marrow in kids than what we have in adults. And by the time you get to adulthood, most of your red marrow, which is where your blood cells are formed, are in your flat bones, in your pelvis, in your skull, in your sternum. So red marrow produces red blood cells. Yellow marrow is primarily just fatty marrow. Medullary canal or cavity is where all that stuff lives. The central cavity are long bones, so long bones kind of like a tube. Regardless of how long the bone actually is, remember your individual finger bones are technically long bones, even though they're very short. So just the shape of them being cylindrical, sort of cylindrical in shape, makes them a long bone. So central axis is where the marrow is, and especially in your long bones, you see that. So you get to trabecular markings, and again, your red marrow is found in the ends of the long bones and also in the flat bones. So you got, again, kind of like your pleura, you got a double lining in your bone. You got a periosteum, which is the outer cover, and then you've got an endosteum, which lines the medullary canal. It's on the inside. So ossification is just bony development. It begins very early in the embryonic life, and it continues all the way through until, some people stop growing by the time they're 14. Some people grow until they're 22, 23, 24 years old. You got two different ways that they grow depending on the type of bone that we're talking about. We've got intramembranous and we've got inchondromal. So flat bones grow through intramembranous, and then short, irregular, long bones, pretty much everything else grows in a similar way, and that is what you're most familiar with. One of the two ways would be through, you've got primary and secondary means of ossification, and you've all heard of growth plates, right? Growth plates are your secondary areas of ossification in things like long bones. Growth plates occur at the epiphysis, or the ends of the bones, and that's where we get our length. Our primary, we tend to think of that as being our primary, but our primary is really the girth of the bone. So mid-shaft is your primary, as opposed to your ends give you the length at the growth plates, your secondary centers of ossification. And it just says that. So our bones classified as long, short, flat, irregular, or sesamoid. Again, long bones, cylindrical in shape, short bones. Not necessarily shorter, long bones. They're just more like a stone shape, right? And then flat bones are just that. They're regular, relatively flat. Your skull bones, a lot of your skull bones are considered to be flat bones, even though they have curves to them. You got irregular bones that don't fit into any of the other categories, and then your sesamoid bones look like sesame seeds. That's why we call them sesamoid bones. So long bones found only in the limbs, and they consist of the body and two articular ends. And articulation is communication, right? So articulation, you speak to somebody, you're articulating words to them, and articulation here is communication. That's all it is. So they've got two articular ends. One bone articulates with the other. So at your elbow joint, you've got three different bones forming that joint space, and they all articulate. So you got like femurs and humerus. Short bones will be things like your carpal bones being your wrist bones. So they kind of like look like individual little pebbles. If I put that in the light, can you kind of see where they break up into individual little bones? Okay, so the short bones, again, not because long tubular shaped bones are long bones and these are shorter tubular shaped bones. That would be your fingers. They're still long bones. Short bones just kind of look like little rocks. And they also have a cancellous bone on the inside and then compact bone on the outside. Carpal bones, tarsal bones, carpal bones are the bones of the wrist that we'll talk about here in a bit. And then tarsal bones are the bones of the feet that are not long bone in shape. So flat bones, again, sternum, cranium. Irregular bones would be things like certain facial bones, certain cranial bones, and the vertebra. They really had no good way to describe them. Flat bones are flat, long bones are long, short bones look like rocks. These things just don't look like anything. And sesamoid bones are, we've got a few different sesamoid bones in the body. The most obvious and the largest would be your kneecap, but they occur where we've got places of very sharp bend, right? So you have some under your thumb, and you've got some under your big toe, and then you've got your kneecaps, your patella. And then some people will have accessory sesamoid bones, sometimes behind the ankle. You'll see that occasionally. But that's just, that's a normal variation, is what they would call that. Okay, so arthrology, study of joints and articulations. So we've got two basic types of joints. They're either functional or they're structural. So they either provide structure, they provide rigidity, or they provide function in the way that you normally think of joints. You think of joints most of the time, you think of bending, right? Well, not all joints bend, and those would be structural joints. So we subdivide those into three. Synarthrosis will be those that are immovable. Amphiarthrosis are slightly movable, and diarthrosis is what you're most familiar with, and that's freely movable. So based on connective tissue types, there's 11 specific types of joints, and we're not going to spend just a whole lot of time on each one of those, but we'll talk about the most significant ones. So fibrous joints don't really form a joint cavity. Joint cavity is going to have your synovial fluid that acts kind of like, like a lubrication whenever you bend your elbow. You've got a synovial joint there, synovial fluid, the capsule, and all that. And in fibrous joints, you just don't have that. Right? So we've got three different types. We've got a syndesmosis, we've got a suture, and gomphosis. Syndesmosis is very slightly movable, and what it does is the most obvious place you see this is in the lower leg. So you got two bones in the lower leg. You got a tibia and you got a fibula, and you got a little bit of motion between the two, but as we'll see in the next section, there are little divots on the tibia that the fibula actually fit into, so that they don't move just a whole lot. But if they didn't have something holding them together, then what would happen is that the little divots that they fit into, they wouldn't be held there very well. So you've kind of got like a compression sock between the bones, not the muscles or anything like that, but between the bones that go from the ankle all the way up to the knee. And that's what a syndesmosis is. And if you've seen, anybody seen an ankle that's been surgically repaired with screws and plates and things like that? Yeah, okay. What you probably saw, in a lot of cases, whenever somebody breaks an ankle, for example, they'll put a plate on the fibula. They'll put a screw in the tibia just to hold the different portions together, and they'll put a screw that goes all the way across from the fibula to the tibia, all the way across both bones to reestablish the syndesmosis. Because what happens in a lot of cases when you break your ankle is you destroy that syndesmosis. So the compression sock is basically ripped so that there's no stability left. So they have to artificially reintroduce that with a screw, and then it becomes, again, more stable and less movable. So that's syndesmosis. It's just a fibrous sock type thing. Then you got a suture, and that's immovable. When you're an infant, you got soft spots, and the bones of your skull actually slide just a little bit. But the older you get, the more those things seal up and the bones fuse together, and that's when you get a suture. So those bones are still individual bones. They're fused together into what we call sutures, so they don't move anymore. Then you got gomphosis, and that's an immovable joint that you only see in the roots of the teeth. So then we got cartilaginous joints, and they don't move much. They move, but they don't move much. So symphysis, like symphysis pubis, is the most obvious, and it gives just a little bit. It's almost like you've got almost like an intervertebral disc in between them, so that you get a little bit of cush there, and it can actually spread out during childbirth to open up just a little bit, so the birth canal really kind of increases in size a little bit, so the baby can move through. So it moves, but it moves only a little bitty bit. If you get a whole lot of movement in a symphysis pubis, what you've got is you've got broken bones. So it doesn't move just a whole lot, but it does give just a little bit. Okay. Synovial joints are what you're most familiar with. So they permit a wide range motion of freely movable, very complex joints. They have a articular capsule, and many have accessory soft tissues like meniscus. Everybody's heard of somebody who's torn their meniscus in their knee, or bursa, a bursal sac, sometimes fills up with, or doesn't fill up, but it contains like little deposits of calcium, and the bursa gets inflamed, and then we have what we call bursitis, and people get very stiff and sore joints because of bursitis. So in synovial joints, we got a lot of different types of synovial joints as well. We got gliding joints, hinge joints, pretty obvious. They basically go back and forth. You got a pivot joint, also pretty obvious, it pivots. Ellipsoid joint, saddle joint, and then we've got ball and socket joints. And ball and socket joints are extremely movable. So a gliding joint, we don't image those just a whole lot for purposes of the joint space itself, but rather for broken bones in some cases. So a gliding joint, you have things like the intercarpal spaces will be gliding joints. A hinge joint permits flexion and extension only. It doesn't really give you anything but that. You may be thinking, well, I can do more than flex and extend. I can also rotate, but you've got two different movements going on there. In the elbow and flexion and extension, there's your hinge, okay? And that's really between the ulna and the humerus, which we'll talk about again here in a bit, as opposed to rotation actually occurs between the radius and the humerus. So you got two different actual things going on there, but the flexion and extension is truly just a hinge joint. So you got pivot joints. Pivot joint would be like where the top of your spine articulates with the skull. This is the first cervical vertebra. We call it the axis, or the atlas. In Greek mythology, who was Atlas? He's the guy that held the world up, right? So you got the atlas, and then you got the axis, and that's where you get the rotation of the head. You get the turning of the head between the first and second cervical vertebra. We'll talk about that here in the joint. An ellipsoid joint not only allows for flexion and extension, but it also allows for abduction and adduction. So an ellipse is kind of like a circle, maybe an elongated circle. So, you know, your wrist joint allows you to not just flex and extend, but also, you know, kind of go around in a circle as well. And a saddle joint would be the joint between the first metacarpal. Okay, so you got carpal bones here, and then you got metacarpals, all the bones of the hand. The carpal bones are the bones of the wrist. Metacarpal bones are the bones of the hand. So metacarpals, carpal bones, and between the first carpo-metacarpal joint, what we've got is a saddle joint. So the saddle joint allows movement similar to an ellipsoid, but it's a little bit different in shape and the way it actually functions. Then ball and socket is probably what you're most familiar with, or what you think of whenever you think of freely moving joint spaces. So you got hip and shoulders. So bone markings, we've got processes and projections, and those are things that extend out from the bone itself. And then you got depressions, and we'll talk about fractures. So processes and projections, we've got a lot of different types. We've got a condyle, and that is a rounded process at an articular end, and you're going to have a tendency to confuse condyle and epicondyle. Let me get a femur real quick. It's the best place to show the difference between the two. So a condyle is something that actually articulates. So what you've got in the femur is you've got condyles. So you've got condyles that articulate with the tib fib. Okay, so condyles. Epicondyles are these things on the side. Okay, so you're going to have a tendency to confuse those two. Condyles are actually at the articular end, as opposed to the epicondyle is not necessarily at the articular end. Condyle, epicondyle. Coracoid or coronoid. I don't really know why they put these together. So a coracoid process is a beak-like process, as opposed to a coronoid process is more like a crown type process. So a coracoid process projects outward. And whenever you go to lab, if you'll look at the skeleton, you'll see in the shoulder, you'll see this thing that just kind of sticks out, right? Just projects from the scapula anteriorly. And it looks kind of like a beak, a dull beak. And that will be a coracoid process, as opposed to a coronoid process. What shape is a crown? You put a crown on somebody's head, what shape is it? It's a circle, right? So it's a round type thing. So your coronoid process is crown-like, and it's round. And where you see that, you see in a lot of different places, or some different places. But can you kind of see right on the proximal end of the radius, if I turn it just a little bit, how round that looks? That's coronoid process. Okay, so it's round, as opposed to a coracoid process would be something more like oblique, this and that. There we go. You see where it's starting to come up and get kind of pointy right there? That would be a coracoid process, more like a beak type process. Okay. Stick on both in your elbow, one on the radius and one on the ulna. The crest is a ridge-like process. Epicondyle would be a projection above condyle. So a crest, iliac crest, epicondyle, we talked about that. It's a projection above condyle. It's not necessarily the articular end. It's above the articular end. So a facet is a joint space. It's kind of like a gliding type joint space, a small, smooth surfaced articular process, and where we see those in a lot of cases is in the spine. So the vertebrae articulate with each other, not just at the disc, but on the posterior side, and we'll get to that later in the semester, on these two flat, smooth articular surfaces, one on either side of the vertebra, and we call those facets. You might have heard somebody having a facet injection, right? They got constant back pain, and they've got some arthritis going on, and they inject some sort of steroid into the facet, or into what we'll call later in the semester, zygapophyseal joints. So a hamulus is not to be confused with the corcoid process. It's a hook-shaped process. The head being an expanded end of the long bone, usually proximal end of the long bone, and a horn-like process would be the horn. A line would be a linear elevation. It's not as prominent as a crest. A malleolus, sometimes you'll hear it's referred to as a malleolus, is a club-like process. So on the distal end of your tibia and fibula, you got these little expanded areas that kind of project down over the ankle itself, or the bones of the foot, and that's what we call the medial. If we're looking at the left, it'd be the medial and lateral malleolus. So protuberance is projecting prominence, like the knot on the back of your head. This is what we call the external occipital, because it's on the back, occipital on the occipital bone, and it's on the outside, external occipital protuberance. It's a knot on the back of your head. And you got a spine as a sharp process. Superior, inferior, and superior, anterior, superior iliac spine would be an example. A styloid process is a long pointed process, and you see those where you've got attachment, ligamentous attachment. In a lot of cases, with a very delicate articulation. You see that thing right there? That's a styloid process. A very long pointed process just behind your ear. A trochanter is specific to the hip. So you've got two trochanters. You got a greater trochanter. This is big wad of goo right here. If you mash on your hip and you rotate your hip back and forth, you can actually feel that passing. So as you internally, externally rotate, you can actually feel that thing going, past your hand. So if you've got a greater trochanter, you're naturally going to have a lesser trochanter. So that's what this thing is on the inside. You can't really feel it, but whenever we get into lower extremity, you'll see how it is that those we image those, or how they should appear. So a tubercle is a small, rounded, and elevated process, and we see tubercle in the humerus. So the tubercle is to the humerus what the trochanter is to the hip. So again, if you mash hard enough on your shoulder with one arm and you rotate your arm in and out, what you'll feel is the tubercle, the greater tubercle, that's like right there, rotating past your hand. You got to really mash on this one though. So again, if you've got a greater tubercle, naturally you've got a lesser tubercle, okay? That groove in between, can you see the shadow right there? That's what you call your intertrabecular groove. So a groove is kind of an indentation in the bone, as opposed to a line being a elevation off the bone. And tuberosity is large, rounded, elevated process. Fissure is a cleft or a deep groove. A foramen is a hole. A fossa is a pit or a hollow space. And then a groove is a shallow linear channel. So a meatus is also a hole, but it's more like a tube-shaped hole, like your ears. Right? I think we've talked about this. Your ears, you've got what we call the external, because it's on the outside. Auditory, because that's what we hear through. Meatus, so it's a tube-like passage that goes to your inner ear bones. enables hearing. So we've got a notch is an indentation and a border of a bone. A sinus is a recess, a groove, a cavity, hollow space. So a sinus in a bone is, we've got a couple of purposes for sinuses. One is resonation, right? The other is to warm air before it gets down into the lungs. And that's a very important thing. Has anybody been to surgery or been to a trauma room with a true trauma in the ER yet? No? You will eventually. And what you find in both surgery and trauma room is in a lot of cases they keep the room hot, like 90 degrees or better. So it's miserable, miserable to work trauma. It's a lot of fun, but at the same time, temperature-wise, it's miserable. You're wearing an apron and you know, a lot of people in the room, a lot of body heat, plus they keep the room hot. And the reason that they keep it hot is to keep the patient's body temperature up, because most of the time the hospital is cold. So the patient comes to us and they're in a little bit of shock, and we put them in a cold room, it makes it worse, right? Kind of the same thing down in surgery. But the sinuses, whenever you breathe, it helps to prevent you from lowering your body temperature and you know, experiencing some degree of shock. With the patient, whenever they're breathing for the patient, the sinuses are completely bypassed and they're just pushing cold air into the patient's lungs, so they have to keep the room hot. So warm the air before it gets into your lungs, and therefore helps to maintain body heat. It lightens the bone and it also gives us resonation. But you also see sinuses whenever we get into the next semester. You've got what you call mastoid processes. You've got mastoids inside of your head, right behind your ear. That's your mastoid process. And it's just a sinus, it's a series of sinuses, individual little bone, holes in the bone, hollow spaces just to lighten the bone up. Okay? So sulcus is a furrow or a trench. And then we've got fractures. And fractures, we've got, you know, fractures and broken bones are the same thing. Your patients sometimes will argue with you. You know, the doctor told them that they got a broken bone, but they didn't tell them it was fractured. It's the same thing. You don't need to try to educate your patients, just nod your head and go on about your business. But we've got basically four types. We've got closed, open, non-displaced, and displaced fractures. So a closed fracture is where the bone is not protruding through the skin, as opposed to an open fracture, it is. A non-displaced fracture is where the fracture lines line up. So the pieces are still in alignment with each other. So a simple fracture where the bone is just broken, is cracked all the way through, but you don't have any kind of displacement or separation between the bone, is non-displaced. And displaced would be the exact opposite of that. You've got some separation in the bones. So within those, we've got a lot of different classifications. We got compression fracture, we've got compound fracture, which is your open fracture. We got comminuted fracture. We've got fractures that are specific to childhood. Those would be green stick and torus. We've got impacted fractures. We've got transverse fractures. We've got spiral or oblique fractures, and simple fracture is just what I was describing in non-displaced. So many of the fractures fall into more than one category. Compression fractures are pretty specific to the spine. So the spine is kind of blocky in shape, and a compression fracture is where you take that blockiness at the height of that vertebra and it just crunches. And it can crunch straight down like that, or it can crunch in a wedge like that, okay? So it's a compression fracture, it just compresses. Compound fracture, you got bones sticking through the skin, a lot of cases blood. Anytime you're taking x-rays of let's say the tib fib, patient's been in a car wreck, and they're still on a backboard, and you get an order for a leg, you walk in, and the knee is straight, and the foot is on its side, put on gloves, because sometimes you'll reach up under the patient, they've cleaned off the backboard, but they haven't lifted the patient's leg and cleaned up underneath it, which they shouldn't. and what you'll find after you get your hand up under there is they've got a compound fracture and it's completely bloody. So, you know, if there's an obvious fracture of a long bone, go ahead and put your gloves on so that you don't get exposed to the blood. So, the bone's sticking out. Comminuted fracture is technically, if you've got a break, let's say you've got a break in the femur, and it's got a break straight across, and it's got a chunk broken off of it. Technically, that's a comminuted fracture. The definition of a comminuted fracture is if it's in 3 pieces or more. If somebody ever says, well, I shattered my ankle, that's what they're talking about. They're talking about a comminuted fracture. So if you have a comminuted fracture where one of the ends is sticking through the skin, you've got more than one category going on there. You got a compound fracture where the fracture is comminuted, right? Childhood fractures, kids' bones don't break in the same way ours do. Our bones are completely not flexible, and kids' bones will bend a little bit before they break. A green stick fracture is just kind of a graphic illustration of how kids' bones will sometimes break. So you walk out to a tree and try to tear a limb off of a tree, just a twig off of a tree. What happens whenever you bend it down? In a lot of cases,
The top part will break.
the top part breaks, the bottom side bends. Okay, so it breaks, but it's an incomplete break, right? You tried to break it all the way through, and it didn't break all the way through. That's why kids' bones will break sometimes, is just like that, just like a green stick. It'll break on one side, doesn't break all the way through. So it's a green stick fracture. A type of green stick fracture is what we call a torus fracture or a buckle fracture. You know, see these in a lot of cases in wrists. You know, a kid falls off a trampoline, falls off a bicycle, and they catch themselves. And what'll happen is, as they catch themselves, the bone will buckle outwards. So what you'll see is, like most of our wrist fractures are actually fractures of the forearm, distal portion of the forearm. So the bone will come down and bulge out a little bit, and that's what we call a torus fracture, okay, or a buckle fracture. So impacted fractures, most of the time your impacted fractures are also going to be where somebody falls down, but this patient's probably osteoporotic. They're an older patient, they fall, they catch themselves, they may break the wrist as well, but sometimes too what'll happen is they'll get an impacted fracture where the neck of the humerus breaks and it kind of slides into the head. Okay, so the head's still intact, but the shaft, a portion of the shaft of the humerus will slide up a little bit. Okay, so it just kind of collapses in itself. Transverse fractures, just like it sounds, it just goes straight across. Spiral fracture or an oblique fracture kind of have a twist to them, and sometimes they're referred to as a bayonet fracture because they're very, very sharp. They can be very dangerous. You know, sever an artery by really manipulating the, you know, not being careful enough with the extremity, picking up a patient without any kind of care. You can actually do more damage to the patient with a spiral or oblique fracture. And a simple fracture and transverse fracture are pretty similar. Okay, so any questions on those? Okay, then we're going to skip into upper extremity. I thought we would. All right, so in the hands, division of the hands, what we've got are phalanges, metacarpals, and carpals. So your fingers are your phalanges. And in your phalanges, you've got individual phalanx. And then the hand bones are your metacarpals, and your wrist bones are your carpal bones. So when we ask you questions or when you're taking a history on a patient, you have to know how to take an accurate history and tell the doctor where the patient's pain is. So what we've got in the phalanges, first off, all metacarpals and all of your phalanges are numbered from in anatomical position, so it's as if the patient would stand up, their hands facing you. and they're numbered from lateral to medial. So the thumb, being lateral most, would be number 1, so it'd be number 1, 2, 3, 4, 5, right? So it will be your, fifth digit, 5, 4, 3, 2, 1. That'd be your, I'm sorry, I just said that totally back, 1, 2, 3, 4, 5. So your metacarpals would also be numbered lateral to medial. You got 1, 2, 3, 4, 5. So when we're talking about, the patient mashed their thumb, but it's not really the thumb, it's proximal to the thumb in their hand, your history would say, injury to the first metacarpal, right? And mash the middle of their hand, that would be which one? Third metacarpal, right? So now we get into the individual fingers. With the thumb, we only have two bones in the thumb, right? You've got an opposable thumb, which means that your thumb, whenever you move your thumb, your metacarpal moves as well. So when you're looking at your own anatomy, keep that in mind. Your thumb truly just starts right there. That's actually metacarpal that's moving with the thumb. So that's keep doing that. First metacarpal, and then you've got your thumb. So each one of those will be phalanx. Your thumb only has 2, everything else has 3, so we've got to number those as well. That will be your first proximal versus your first distal phalanx, okay? So you only have 2, so you got proximal and distal. All the other ones, we've got proximal, middle, and distal. So we got 3. So it's not just enough to know that, but you've also got to know how to articulate exactly which joint space the patient may be having a problem with. So let's say that they mashed their joint on, let's say the second, on their index finger, the joint space between the middle and the distal. What you would say is that is the patient they might have crushed their, which number? Second. Distal interphalangeal joint, okay? So we can abbreviate. If we're talking about this joint space right here, this would be an interphalangeal joint, that would be an interphalangeal joint. So that's a distal, and that's a proximal interphalangeal joint. So if they mash here, that would be your proximal interphalangeal joint, that would be PIJ. Okay, IPJ. Got dyslexia bad today. IPJ, interphalangeal joint. Okay, now down here we got metacarpophalangeal joint. So that's your metacarpal bone, and that's your phalangeal joint. So this would be the second metacarpophalangeal joint, MPJ. Okay. All right, you got that? Then you got your carpal bones, and your carpal bones, you got 8 carpal bones. And the one that we fracture most commonly, and we've got some special views of, is a scaphoid. It used to be called the navicular, so some of you techs in the hospital will refer to it as either the scaphoid, the navicular, or sometimes the scaphoid navicular. They're all saying the same thing. It's that bone right there. And that is the lateral most proximal bone in the wrist bones, truly in the wrist bones, the scaphoid. So what we have is scaphoid, lunate, tricatrum, pisiform. Now, pisiform is almost like sesamoid bone. It's a little bitty bone. And then you got the trapezoid, trapezium, and the capitate is the largest bone, and it's in the distal row right in the center. And then you got a hamate. And the hamate on the anterior surface, you got a hamulus. It's really the only place in the body I can think of that has a hamulus, going back to the terminology in chapter 2. So all of that we just talked about. So it's just a mnemonic that's in the textbook to remember how to locate the individual bones. You're not going to hear anybody refer to that particular mnemonic in the hospital. They got a different one that they'll, I'm sure, brief you on at some point. So interphalangeal joints, metacarpophalangeal joints, again, we talked about that. So proximal to that, what we've got are carpal metacarpal joints. We don't really number those so much or really memorize exactly which carpal bone articulates with which metacarpal, but those are your carpal metacarpal joints. There. Okay, so any questions on those? No? Why don't we're a little bit early for a break, but before we, start into procedures, why don't we go ahead and take about 10 minutes, and then we'll come back and we'll just go straight through to 10:20. Instead of breaking up the positioning portion. And we're going to chance it. So what we found out last week when Trina's recording failed is if you get a phone call, it stops the recording. Hopefully that doesn't occur. So anyway, whenever you have a patient for any kind of exam, you're going to need to remove whatever artifacts you can from the patient. Sometimes you're not going to be able to. Casting material you can't take off. If the patient has any kind of splints, it's not your job to remove splint material because if you do and it causes greater problems with the patient, compromises blood flow or whatever, then that is you're personally and professionally liable. So know what you can take off, know what you shouldn't take off. Splinting material, casting material, certainly not, but things like bracelets and rings, if they will come off, really need to come off with the patient. So patient preparation, remove whatever artifacts you can. General patient position, extremity work. Try to make it as easy on the patient as you can. If the patient comes in, they've got a broken hand for whatever reason, there's absolutely no reason to put them on the table, right? The only reason to put a patient on the table is if you're shooting an extremity work, something like a leg or a knee or a hip or something like that. There's no reason whatsoever to put a patient on the table for hands and fingers. So you can put them in a chair and move them up to the table, but make it as easy on the patient and therefore on yourself as you can. A couple of things about image receptor collimator size is if you have different sizes of image receptors, always use the smallest image receptor that you can get away with. There's no reason to put a hand on a 14 by 17 image receptor. So smallest image receptor you can, but a lot of y'all are using the same size image receptor as 17 by 17 or 16 by 16. So what's your general rule for image, or not image receptor, but field size, collimation size?
Collimate to the hand.
Collimate to the part, right. So you want to use the smallest image receptor possible, and you want to use a field just to include the anatomy that you want to see, and you never want to have a field larger than the image receptor, right? So collimate to the part, never larger than the image receptor. Most of our extremity work's going to be shot at 40 inches. The book, sometimes says 48 inches, 48 inches. Really, the difference is pretty insignificant. Use your markers, make sure that you mark properly. That is to say, left marker with the left anatomy, right marker with the right anatomy. Some of your doctors, anybody in Jacksonville? Okay, ETMC, yeah, or UT, yeah. It'll always be ETMC. Dr. Bennett's pretty specific on how he wants his markers used. So if you rotate out to Jacksonville and you're at UT Health, make sure that you familiarize yourself with his policies. Some of your older techs will be pretty specific in where they want the marker placed. My personal opinion is if it's a proper marker and it's on the image receptor and it's not in the anatomy, it's marked, right? But some people are pretty specific, pretty particular. So make sure that you know that. Okay, so the system blinked. The So make sure that you know what protocol is. Now, even though you're shooting extremity work is going to be very low dose, it still is dose, right? So, if you put the patient into, or put the patient in a chair and push the chair up to the x-ray table, x-ray bed, and you shoot tabletop, which you should be shooting tabletop, no reason to use a grid for most of your extremity work, or at least half of it. Keep in mind that what you're going to be doing is putting the patient on the image receptor, or in the chair, image receptor on the tabletop, so that they can see it. Put the image receptor on the tabletop, and you're going to move the patient up to the table. Let's say you're shooting a hand. What are the characteristics of the tabletop? What do we have to have in the tabletop? We've been through this in physics, so you should know it. What characteristics do the tabletops have to exhibit? X-rays have to go through them because the image receptor's underneath, so that it means that they are radio opaque or radiolucent? Radiolucent, right. So you put the patient in a chair and you put the chair right up under the tabletop and you put the hand on the image receptor. What are you shooting into?
Body. Into the person?
Yeah, you're shooting into the person, you're shooting into their hand, but what's directly below the hand? The image receptor. What's directly below the image receptor? The tabletop, which is radiolucent, right? And they're sitting right up under the table, or what's right up under the tabletop? They're gonads, right? So go ahead and put, even though it's low dose to the patient, go ahead and put an apron on the patient for extremity work to limit that dose. They're not going to get a whole lot of scatter back up into their face or into their chest or thyroid. But if you've got them sitting on a table, they're going to get some forward scatter directly into their lap. And so we want to protect that. So radiation safety. Main radiation safety in this case is going to be collimation, but secondary to that is going to be put an apron on the patient. I'm back up here. I have to turn those off. Okay. So, individual fingers. What we're going to do with individual fingers is, again, the smallest image receptor that you can get, but still collimate to the part. Don't use an entire image receptor for individual fingers. Some of your hospitals won't request individual fingers, they'll shoot hands. Some of your hospitals will ask for individual fingers, but they want adjacent digits as well, especially in the toes, but sometimes in the fingers as well. So let's say you smash your index finger, what they'll want you to include is, in some cases, the thumb and the middle finger. Okay, so adjacent digits. Now, when you're studying for the test for extremity work, you're going to have a tendency to, look at central ray entrance, central ray exits, and sometimes they're very specific. But just think about what you're trying to shoot. So individual fingers, what you want to see is both ends of the finger, but you don't want to collimate so tightly that you go right through the joint space. One anatomy doesn't start until the other anatomy ends. Is that going to make sense? So the finger doesn't really start until after the metacarpal ends. Okay? So if you're looking at your own hand, what would include the tip of the finger all the way to the end of the metacarpal? If we're looking, let's say, at the index finger, and you had to look at that and say, I want to put my central ray right there. Looking at your own anatomy, where would you say? That knuckle, okay. But we're not going to say that knuckle on the test. We're going to say what? The proximal interphalangeal joint, right? Okay, so it's not as complicated as what it seems like it might be by reading the textbook. It looks like we're gonna have one dead screen, so we'll just make an adjustment. It's not as complicated as what it may seem like by reading the textbook. Just look at your anatomy and look at the middle of the anatomy, and that's where your central ray goes. So you're looking at your hand. If we're shooting a hand, what's dead square in the middle of the hand if we want to include the carpal bones? And the metacarpal and all the way to the tip of the fingers.
Metacarpal?
What's that?
Metacarpals?
Okay, metacarpal, but maybe that knuckle right there, right? If I go measure from here down, right? That pretty much puts it right in the middle, doesn't it? So what do we call that? Third. It's not inner, because inner would be here. So it's between the metacarpal and the phalangeal, so it would be the third metacarpal phalangeal joint. Right, okay? So you're looking at a forearm. What's in the middle of the forearm? The middle of the forearm, right? So, don't overcomplicate it, you know? Just look at your anatomy and say central ray femur is gonna be to the mid shaft of the femur. Humerus is gonna be the mid shaft of the humerus, okay? So, we just covered pretty much from humerus, the central ray location from humerus all the way down to the tips of the fingers. You're just gonna put the central ray in the middle of the anatomy. Middle of the elbow, middle of the elbow, middle of the humerus, middle of the humerus, middle of the forearm, middle of the forearm, middle of the carpal bones. You get it, right? So don't overcomplicate it. So digits 2 through 5, we're gonna cover all at the same time because our positioning is gonna be identical. So that's digits 2. So from anatomical position, lateral most is number 1. That's your thumb. So 2, 3, 4, 5. They're all going to be positioned the same. So what we're going to do is we're going to extend the fingers. If the patient can extend the fingers, have the patient extend the finger and put it parallel with the long axis of the image receptor. Central ray. Well, first off, separate the digits just a little bit to make sure you don't get soft tissue overlap in between them. So just separate them a little bit. That doesn't mean you have to fan them out like that. Just separate them enough to where they're not going to overlap each other. Okay? So separate them a little bit with the affected digit in the center of the image receptor. Central ray perpendicular to the image receptor enters at the proximal interphalangeal joint. That's your fingers from 2 through 5. Okay? So in our positioning, we're always going to take at least 2 images of the anatomy. And we kind of walked through this before. And the reason for 2 images is so that we get a 3-dimensional perspective, right? So let's say we've got a broken, let's say wrist. And I look at the wrist, let's do it this way. I look, marker's not going to cooperate with me very well. So just looking at shadow, not looking at the cap or the marker itself, does that look like it's lined up? It looks like it's a little bit separated, but does it look like it's lined up this way?
Yes.
Yes. So if I turn it though, does it still? No. Okay, so in an x-ray, what we're looking at is a shadow of the bones, right? And just so that you can see over there, we're looking at the shadow of the bones. So we see a 2-dimensional perspective. We can see length and width, but we can't see depth unless we get, 2 views 90 degrees from each other. Now we can say, well, it's a line, but it, depending on which way it's going, it may be, the distal fragment may be anterior, it may be posterior, it may be, going in one direction or the other, side to side, which they call varus and vagus. Valgus. So we've got to get 2 views. Most of the time that's going to be AP and lateral or PA and lateral. In the fingers it's going to be PA and lateral. So we're always going to do at least 2 views, probably 3. So we're going to try to position the patient so that we get the best image without distortion. Well, what's distortion? Distortion is a misrepresentation of the anatomy. We've got a lot of different types of distortion, okay? If I'm looking at the shadow of this, I want this to be as close to the screens as possible so I don't get magnification, right? With the magnification, what do I get? It's a fuzziness, so I lose sharpness or recorded detail, right? So I want it as close as possible so our OID is as small as possible, right? But I also want it parallel, because if I have it tilted, all right, so this thing is that long, right? But if I tilt it, how does it look now? Does it look longer? Does it look shorter? What do we have going on? It looks shorter, okay, so that's foreshortening. So we want it parallel to the image receptor with the central ray perpendicular to the anatomy, if at all possible, to minimize distortion. All right, so how we're going to maintain the lowest OID is by rotating the anatomy into a lateral depending on which would put it closest to the image receptor. Okay, so if you look through this, lateral, the second and third digits extend in the affected digit with the lateral surface in contact with the image receptor. Okay, so we went from here. Where's the lateral surface?
On their side?
Well, which side? This side or this side?
The pinky side.
You would think so because you're looking at it, right? But remember, medial and lateral is according to anatomical position. Okay, you're going to do this on the test. Don't do this on the test. Go all the way back to the anatomical position. So the second and third digits you're going to put on the lateral side, which is going to look like your medial side, but it's anatomical position. So for the second and third digits for lateral, you're going to put it down like so, okay, on the lateral side. Okay? That minimizes OID. What you're going to have to resist the temptation to do is to take a finger, especially the third finger, and tilt it. Well, I want to maintain my OID, a low OID, so I want to do that, right? No, you don't. And the reason you don't want to do that is because you have just taken your anatomy and it was parallel to the image receptor by being extended, and you put it at an angle to the image receptor, and you're going to get foreshortening. Okay? So even though you're going to get a little bit of an increase in OID here, you don't want to tilt it down like that because you get foreshortening. So keep it parallel to the image receptor. The other thing is this. What we're going to be evaluating, the central ray needs to go through the joint space, so it's got to be parallel to the joint space. The joint space has to be perpendicular to the image receptor. So now this becomes joint space. Okay, this little gap right there becomes joint space. So can you see joint space? Maybe not all the way through it, but this is a flawed demonstration. But can you kind of see where it is right there? The separation between the cap and the pin? If I tilt it, what happens?
You can't tell.
It goes away. Okay, so by tilting the anatomy, you also lose joint space. So keep the anatomy parallel, even though you've got an increase in OID, keep the anatomy parallel to the image receptor. Keep the joint space perpendicular to the image receptor so that the central ray can go through it. Central ray should be parallel to the joint space. So that's 2 and 3. 4 and 5, we're going to rotate in the opposite direction. Again, from anatomical position, what we're going to do is we're going to rotate and put the medial side down for 4 and 5, and we're going to do the same thing. Okay, so bend all the other fingers out of the way. You got number 4, or you got number 5. Number 4 presents a bit of a challenge. The textbook says bend all your other fingers and extend number 4. Can you do that very well? I can't. What I can do better is extend all the other fingers and bend that one, if at all possible. If the patient can't bend the finger, what you can do is bend these two and do that, okay? So that is better than this, right? You got a lot of superimposition there as opposed to a little bit there, okay? But in that case as well, you want to keep the anatomy parallel to the image receptor if at all possible, right? Keep the anatomy parallel to the image receptor. That puts the joint space perpendicular to the image receptor and the centroid parallel to the joint space. Okay, you're good with all four of those? Because the thumb is totally different. Well, while we're on it. Obliques. Sometimes your hospital will ask for oblique. And unless I point out otherwise, from here until the end of upper extremity and really the lower extremity, all your obliques are going to be 45 degrees. All your obliques are going to be 45 degrees. So when I talk about elbows, I'm talking about obliques. What's your degree of obliquity? 45 degrees. If I talk about wrists, your degree of obliquity is 45 degrees. Hands? Okay. All right. So that's you shouldn't get that wrong if you get wrist oblique is 60 degrees, true or false. That is going to be false, right? So 45 degrees unless otherwise stated. All right. So what you'll see in a lot of cases is your technologist will shoot PA, and the oblique is going to go in the same kind of general direction as the laterals. So you'll shoot PA, and you shoot a 45 degree oblique, and then you'll roll up into a lateral. In a lot of cases, it's just the routine if you happen to shoot 3 views of the finger. And in the finger itself, the oblique really doesn't show you a whole lot more than what the PA and the lateral will. But some hospitals call for 3 view. So it's 45 degree oblique. The thumb, though, is a totally different animal. The thumb is the only bone that we're going to shoot AP instead of PA. So we're going to shoot AP, lateral, and oblique on the thumb. The positioning is totally different. All right, so laying your hand on your tabletop, take a look at what position the thumb's in. Is it? Yeah, it's oblique, right? So it's not prone. Your hand is prone, right? Your hand is prone. But your thumb is oblique. It's not lateral, it's not prone, it's oblique. So when we talk about the oblique, PA oblique, what position do you think your hand is going to be in to give you oblique of the thumb? It's prone, right? So naturally it gives you about a 45 degree prone position. Taking your hand, you've got, what would be the best way to move your thumb into a lateral position? Okay, you get a little bit ahead of me, that's your AP. But a lateral position, really all you got to do is take your fingers and bend them up, and that rotates your thumb straight up like so. Okay? Okay, so the AP is what is really the tricky part about the thumb. There's a couple of different ways to get to it. All right, you can either take the patient's arm and totally rotate it all the way around to where the thumb's pointing straight at the sky, or if the patient can perform it, you just have the patient put a little body English on it. They're sitting at the table, and they're going to lean down and just put their thumb directly on like so. Or if you're working in a hospital where you've got a removable grid in your wall bucky and you can still shoot tabletop, you can take that grid out and just have the patient stand up and shoot directly into it, like so. The catch here is that for your thumb, it's the only digit we're going to shoot AP, but it's also the only digit that we're going to shoot all the way down to the base of the first metacarpal. Okay, so we're going to include the entire metacarpal all the way to the carpal metacarpal joint space, and that is because whenever you move your thumb, you move everything. Okay, so your collimated field is going to go from about a ½ an inch past the tip of your thumb all the way to the carpal metacarpal joint space. The problem with rotating like so is that in a lot of cases what you get is you get that rotation and the patient can't really rotate enough to get the rest of the hand off of the proximal end of the metacarpal. Can you kind of see how that might be a problem? All these bones, all the carpal bones are going to be projected over the proximal end of the metacarpal. Now, the patient can rotate around enough to keep the thumb AP and get all that stuff out of the way. fine, they can do that. But if they can't, then you need to find a different way to position the patient, possibly again with the patient upright. So since we've got to get all the way down to the proximal end of the metacarpal, what we've got to be careful of is not putting the rest of the hand directly over the proximal end of that metacarpal. Extend the hand enough so that you can see the carpal metacarpal joint space. Okay? So AP. However, you got to get the patient into AP. That's the only digit we're routinely going to do AP. Lateral, just bend the fingers up a little bit to get the thumb into lateral. And with the hand prone, then you're in a natural oblique position for the thumb. Okay? That just says all that. So pathologies of fractures, arthritis. There are a couple of different types of arthritis. You got rheumatoid arthritis and you got osteoarthritis. Rheumatoid arthritis is systemic, and it can be a nasty condition. You know, if patient's not on medication, kind of slow the progression of it. Have you ever seen somebody whose fingers just look like they're kind of deformed? Usually older patients and their fingers going in different directions. That's usually because of rheumatoid arthritis. And whenever you take an x-ray of a patient with rheumatoid arthritis, the bone looks a lot like a patient who has osteoporosis. The bone is just degenerating, especially at the articular ends. The bones are basically dissolving. As opposed to osteoarthritis is just natural aging process. You know, most people who complain of aches and pains in their fingers and stuff like that are suffering from osteoarthritis. That's just inflammation of the joint space, normal wear and tear. A Bennett's fracture is a common fracture of the proximal first metacarpal. Anybody ever been snow skiing? Nobody's ever been snow skiing. Okay. Anybody ever had any kind of an injury where you're holding on to something that you can't let go of for whatever reason, and you get this pain right down in here? Never had that either, huh? Okay, well, a Bennett's fracture is called a ski pole injury because it's very common whenever when you go snow skiing, you got this big long ski pole and it's got a strap around the handle, right? So you go to fall down, and if you ever go snow skiing, you're gonna fall down. And you have a tendency to dig those poles in, and what happens is it wrenches your wrist. And in some cases, you wind up with a fracture of the proximal first metacarpal, and it's called Bennett's fracture. Also, again, known as ski pole injury. It can happen elsewhere, you know, with other similar types of injuries, but specifically it's known as ski pole injury. So right there is what a Bennett's fracture looks like. See that right there? That line going straight across? You know what that is? It's a growth plate. So what we know about this patient, not so much this one, but what we know about this patient is they're probably a late teenager. I say a late teenager because you see all these carpal bones. These are all your carpal bones here. In young pediatric patients, the first time you take a x-ray of a kid's wrist or hand, you'll be shocked by how few bones they actually have. It's all cartilage and you can't hardly see it. So the rest of the bones are very well delineated. Oddly enough, the rest of the metacarpals look like the growth plates are sealed up, but in that particular thumb, the thumb's still got some growing to do. So osteoarthritis, you may see some narrowing of the joint space. You see how you've got good joint spaces here and here, but they just kind of get skinnier and more narrow, and it looks like the bones are actually touching. That would be your osteoarthritis, as opposed to rheumatoid arthritis. We've got physical deformity of the joint spaces. Okay. Any questions on the fingers? So the hand, again, we're going back to PA. We're going to do if the patient can extend their fingers. I've had patients who could not extend their fingers either because of pathology or because of injury, and we'll talk about that here in a bit. But most of the time we're going to do PA. Most of the time we're going to do PA and lateral. Sometimes we're going to do oblique, and our degree of obliquity is going to be
45.
45 degrees. Very good. All right, so PA. Again, move the patient as little as possible. Put them in a wheelchair. Put them in a chair. Scoot them up to the table. Put an apron on them. All that. Obviously, if the patient's on a stretcher, you don't have to put them in a chair. You shoot them on a stretcher, right? You don't have to move them even to the X-ray table. You can put them on, shoot them on a stretcher. So sit the patient at the end of the table if the patient's a walkie-talkie. Adjust the height so the forearm is resting on the table. You can collimate down to, the reason that we go with a ½ an inch to an inch on all sides plus the end of the finger is because your collimators can actually be inaccurate. If you collimate all the way down to the skin line, you feel that you don't have just a whole lot of skin on certain places in your extremities, right? So if you collimate all the way down to the skin line and your collimators are inaccurate, then you're gonna clip anatomy. So give yourself a ½ an inch to an inch beyond the skin line in order to not do that. All right, so central ray again is going to be to the middle of the anatomy, palmar surface on the image receptor, forearm on the table. Now, the reason they point out forearm on the table is because if you just maybe the patient don't want to sit down, right? The patient walks in, they say, I can just put my hand right there, right? And they're at an angle like so. Well, what you're going to do is you're going to open up your collimator to make sure that you include all the metacarpals. So if you're including the metacarpals and the arms at an angle like that, then you're just not going to see the intercarpal joint spaces very well. So have the patient sit down, have the patient kneel. If they don't want to sit down, they can put a knee on the ground, and the forearm needs to be down and not at an angle to the image receptor as well. Okay, so just get them low enough to get the forearm on the table or on the image receptor. So central ray again is going to be right in the middle of the anatomy, third metacarpal phalangeal joint. Central ray is going to be perpendicular to the third metacarpal phalangeal joint. Now, point this out for the test. Whenever the test comes up, central ray has to go through the joint space, right? It has to go through the joint space. So if the space in between these represented the joint space, then the light has to be parallel to the joint space itself, okay? So to see open joint spaces, the central ray has to be parallel to the joint space, okay? That's not what this is saying. It's saying your central ray needs to be perpendicular to that anatomy. So it needs to be perpendicular to right here so that it will go through the joint space. You see the difference between those two? It's got to be parallel to the joint space. It's going to be perpendicular to the anatomy. Okay? Don't let that trip you up on the test. So, the hand, oblique of the hand, again, it's going to be 45 degrees. And what you'll see some technologists do is they take the hand, they shoot PA, so forearms all the way down on the table, they shoot PA, and then what they'll do sometimes is tell the patient to make the OK sign, okay? And it'll rotate the hand up naturally into about a 45-degree angle. The problem with this, and a lot of hospitals, a lot of doctors are okay with it, and if they're okay with it, I'm okay with it. But the problem with this is, what does that do to these fingers? Pinky, not so much, but the rest of the fingers, what does it do? It puts them at an angle to the image receptor. So are you going to be able to see those joint spaces? No. All that anatomy is going to be foreshortened, right? So we've got two different obliques and two different laterals. And if you're really interested in seeing the joint spaces, and if you're really interested in seeing the length of the bones, then what you need to do is elevate those fingers. You still have a 45-degree angle, but you need to elevate the fingers off the image receptor to keep them parallel with the image receptor, okay? So There'll be questions on the test that say, you know, what if you use the fingers as props for oblique of the hand? Well, what would you say? The two things. You get foreshortening of the anatomy, and you don't see the joint spaces. So if you're interested in seeing the joint spaces, what do you not do? Use the fingers as props, right? Okay? The lateral also, we've got two different laterals. One being what we call a fan lateral. So we shot our PA, left the patient kneeling on the floor or sitting in a chair or whatever. We're rotated up into a 45-degree angle. Whether we use props or not, fingers as props or not, is irrelevant. We've got a 45-degree angle. 45 degrees is the angle of the metacarpals. Okay? So now we're going to rotate up into a lateral. And we got two different laterals. One lateral is where the fingers are extended. That's referred to as lateral in extension. So fingers are extended like that. Central ray in all three of these cases is going to be the third metacarpal phalangeal joint. Make sure you take the thumb, you know, because what you'll have a tendency to do is tell the patient, I want you to put your hand up here like you're karate chopping. So what is the patient going to do? You're going to do right like that, right? So can this get out of the way of everything else? All of your metacarpals 2 through 5 are going to be superimposed. You can't get past it. But can you get this one out of the way? Absolutely, absolutely. So you need to put it down in front, okay? Now your problem is going to be this. You're going to have a tendency, because you know y'all are trying so hard to get everything just perfect, right? So you got your hand right there. You say, okay, central ray needs to be right here, spot on. My collimation needs to be 1.5 or 1 inch to a half an inch to an inch away from the skin level. So you're going to collimate, you're going to collimate, you're going to collimate, and what are you going to do?
Chop the thumb off.
You're going to chop your thumb off, right? So make sure, and it happens sometimes on PA as well, make sure that you don't neglect the poor thumb, right? You don't want to scrunch the thumb in like that, so keep it separated, but make sure that you don't collimate the thumb off on the PA or the lateral, okay? So make sure you pay attention to the thumb. The problem with this is that if the patient has a fracture in one of the phalanges, you can't see it, right? Because all of them are superimposed on top of each other. What this is good for is if the patient, let's say they work with metal and they've got a foreign body, you know, they got a shard of metal that's stuck into the palm of their hand. It's good for showing that because, you know, if the shard of metal is right here, we can see exactly where it is in this dimension. And when we rotate up, we can see exactly how far it is that way, right? It's good for foreign bodies, but for fractures in the phalanges, it's useless. So if we're interested in seeing fractures in the phalanges, what we need to do is, again, go to our OK sign, resist the urge, or have the patient resist the urge to really go, okay, you know. They don't need to be mashing their fingers together. Just get them to make a lazy OK sign and fan their fingers out. So fan lateral, good for fractures. Extension, good for foreign bodies. Okay? Both of them you'll see fractures. You'll see the displacement of fractures in the metacarpals. But in the fingers themselves, we need to separate the fingers so that we can, you know. You can't separate the metacarpals, but you can separate the fingers. Okay? Any questions on those? So if the patient can't extend their fingers, you know, maybe they've got rheumatoid arthritis and they just can't straighten their fingers out, it would be okay to shoot at AP. Had a patient one time that he cut pretty much all the tips of his fingers off. And in doing so, it destroyed all the tendons in between the fingers. He was mowing and the grass was wet and he didn't want to restart the mower, so he reached into the port and just started pulling the grass out of the port with the mower running, and he just reached in too far and it took every tip of every finger off. And he couldn't straighten his fingers out. He had no ligamentous attachment. So, in that case, you got to shoot AP, because shooting PA, he was literally like this, So he had to flip his hand over and shoot AP. So there are times you may have to shoot AP, but most of the time PA. All right, so wrist. We've got a lot of different views of the wrist. We're not going to cover the carpal canal. Tina will cover that, or Trina. Tina's my wife. Trina will cover that in your second year, but we'll talk about all these others, and we'll actually talk about a hybrid here between what's actually in the book and what you'll see in clinics. So again, we'll shoot PA, we'll shoot lateral, we'll shoot PA oblique, we'll shoot what we call ulnar deviation, which is for the scaphoid. We'll shoot a Stetcher method, which is also for the scaphoid, but we'll do a hybrid between these two, which is, again, what a lot of hospitals do. Why they don't have it in textbook, I'm really not sure. Okay, so again, positioning starts out a lot like a hand. Put the patient in a chair, put the patient at the end of the table. You're going to be shooting through the table. Make sure you put an apron on the patient. But what you want to do is you want to align the shoulder, the elbow, and the wrist all in the same plane. And here's why. The evaluation criteria, if you read through the book, the evaluation criteria is that, a little knot on the medial side of your wrist, this is medial, right? That is what we call the ulnar styloid process. Okay, the ulna is that bone on that side, and that's ulnar styloid process. And the evaluation criteria calls for the ulnar styloid process. I should turn this back around this way. The ulnar styloid process to be in profile. When you talk about profile, what are you talking about? Mugshot, profile, what do you got? It's a side view, right? So it needs to be out there to the side. All right, so if you put your hand down on the table, what do you feel? It's poking out back, right? So it's posterior, it's not out to the side. But if you take and you just keep your finger on that and you elevate your arm until everything is at shoulder level, what do you feel? So you get it down here, you feel it sticking out of the back, and you come up, and you come up, and you come up, and what happens?
Disappears.
It disappears, right. So it rotates out so that you would see it in profile. So whenever you're shooting a wrist, and I'm just going to go ahead and say forearm and elbow, what you need to do is you need to get the patient on a level so that their shoulder, their elbow, and the wrist are all in the same plane. And the wrist, that's why. In the elbow, we'll talk about that whenever we get to it. But get everything in the same plane. So your collimation is going to be 2.5 inches proximal and distal to the wrist, and 1/2 inch to 1 inch on both sides. Okay, and the reason we're going 2.5 inches, which pretty much puts it in the middle of the hand to the distal third of the forearm, is because most of the fractures of the wrist are not really in the wrist bones, but in the distal portion of the radius normal. Okay, patient falls down, they catch themselves, and most likely what's going to snap is the distal portion of radius normal. Distal portion of radius probably before anything else. So what you'll see in most of your wrist bones, we talked about the kid bones with buckles and all that earlier, but in adults what happens in a lot of cases is that the distal fragment will pop out and it'll be projected posteriorly just a little bit. Because the patient falls, they catch themselves, and the momentum snaps it off backwards. Okay? All right, so upper extremity on the table, entire upper extremity in the same plane, elbow flex to 90 degrees. Place the wrist in the center of the image receptor. Flex the fingers just a little bit, and you're going to tell the patient to make a fist, but not a tight fist. And again, put your hand on your table, put your hand on the table, and then what do you see here? I can see you right up under that, right? So we have an increase in OID, right? So to decrease that OID, what we're going to do is we're going to bend the fingers, okay? If you bend the fingers, then it decreases the OID of the carpal bones and puts the carpal bones closer to the image receptor. If you tell the patient to make a fist, they're gonna have a tendency to really ball up and make it tight. And if they do that, then it defeats the purpose. You go from contact to lack of contact again, okay? So just tell the patient, I want you to ball your fingers up a little bit, just bend your fingers and watch for when you've got no gap in between the wrist bones or the anterior portion of the wrist and the image receptor. So bend the fingers, all right? And the central ray is going to be perpendicular to the mid-carpal area, right in the middle of the anatomy. All right? So then you're going to go from that to lateral. Again, lateral gets a little bit more complicated than the lateral of the hand. In the lateral of the hand, all you're doing is trying to take the metacarpal bones and stack them on top of each other. So, you know, you can take a patient's hand and you can kind of sandwich it in between your hands and kind of make adjustments, right? And whenever these things are vertical, then you're lateral on the hand. It's not the same thing with the wrist. Okay, your evaluation criteria on the wrist is to have your radial styloid process, which is a little bit harder to feel, but it's on this side, right here. Radial styloid process and your ulnar styloid process superimposed, so they need to be stacked on top of each other. But you've got your radial styloid process, again, even if you're, everything's in the same plane, but you've rotated into a lateral, it's sticking out back again. Okay, there's no way to get it, you know, in profile. So what you're gonna have to do is you can use the carpal bones, the metacarpal bones, to judge whether or not the hand is vertical, right? But what you need to do in a lot of cases, in a lot of patients, is slightly superimpose the hand, or slightly supinate the hand, so that you get the hand vertical, and then from vertical, what would be a lateral of the hand, you need to supinate the hand maybe 5 degrees. So it's from here to maybe here. Very slight, very subtle supination, okay? So what that'll do is that'll take the ulnar styloid process and it'll project it more anteriorly, so that, and the radial styloid process more posteriorly, so it'll be superimposed. So when the hand is lateral, those two styloid processes are here, and if you slightly supinate, it brings them more together, okay? But it's very subtle, very slight. So lateral wrist, just like lateral hand, only slightly supinate. In the oblique of the wrist, you can use the fingers as props here. You're not interested in seeing those interphalangeal joint spaces, so you can just tell the patient, I want you to make the okay sound, rotate up to 45 degrees. External rotation, 45 degrees. Okay? Any questions on PA, lateral, and oblique hand, or wrist? All right, then ulnar deviation. So most commonly fractured wrist bone is going to be the scaphoid. The problem with scaphoid is in its normal orientation, what you've got is a bone that's it's a little bit hook shaped. It's not like a handulus or anything like that, but it's a little bit of a complicated shaped bone. So if you were looking at it from a lateral perspective, it's kind of like that. So from a PA or AP perspective, it's like so. So again, what we've got is anatomy that's not parallel to the image receptor in PA, okay? Which means we've got foreshortening. The problem is that fractures, much like joint spaces, if the central ray isn't parallel to the fracture, we're back to this. You know, we got good joint spaces and we got no joint spaces. So if the fracture in the scaphoid is down here, then it'd be kind of like trying to see this joint space with that finger bent. Would you be able to see it very well? No, you wouldn't. So the ulnar deviation and the Stetcher method both seek to try to eliminate that. In addition to this, what we've got is superimposition of the bones. So all the bones are kind of bunched together like so. And with our ulnar deviation, what we're going to do is we're going to do like PA of the hand, PA of the wrist, and we're going to flex the wrist towards the ulna. Okay? What that does is it takes all those bones that are kind of bunched up together and it separates them, like so. Okay, so instead of being bunched up like that, they're going to be separated more like that. So we've got ulna here, and it takes it, or I'm sorry, we've got scaphoid here, and instead of having all these bones bunched up on it, it's going to separate it as much as it can out by itself. Okay? So again, it's kind of like PA. You're going to get everything in the same plane. But before you get ready to shoot your image, you're going to have the patient flex the hand as far as they can towards the ulna. That's why it's ulnar deviation. You're deviating towards the ulna. Images in the book show the entire wrist. The only bone that you're looking for is the scaphoid. You can collimate down to an area just about the size of the cap of that pen. Okay? You don't need the entire wrist. If the hospital protocol is to show the entire wrist, and if that's what your doctor orders, then yeah, show the entire wrist. But if he doesn't specify, you can collimate down to just half of the wrist. The only thing you're looking for is the scaphoid. Okay? Problem is that if somebody's got a lot of pain in the wrist, this is really difficult for them to perform. So get everything set up, and the last thing that you have the patient do is do that ulnar flexion. Right? Have to make sure you have your machine set up so that the last thing that you do is have the patient ulnar flex, and then go make your exposure, tell the patient to relax. Okay. We'll take a look at what that looks like here in a minute. The Stetcher method is a PA of the wrist with a 20-degree cephalic angulation. All right, so, and you can accomplish this in a couple different ways. The most common thing to do would be to have the patient put their hand flat on the image receptor, and then angle the central ray 20 degrees in this direction, and what we're trying to do is trying to get the central ray more perpendicular to that distal portion of the scaphoid that's already at an angulation like that. Okay? So where the ulnar deviation separates the bones and it might overcome a little bit of that angulation, it doesn't overcome all of it. Where the Stetcher method overcomes the angulation, it doesn't overcome the superimposition of the other bones at all. It overcomes the angulation, but you still got the superimposition issue. So a lot of your hospitals, every hospital I've ever worked in, they did a scaphoid view. And the scaphoid view used both of those things. So what we did, or what you'll do, is ulnar flex to get rid of that superimposition, then use the 20-degree cephalic angulation in order to overcome the angulation of the distal portion of the scaphoid. Okay? So it's both of them with this scaphoid view that you'll probably see in the hospital. So is there any other way to get that 20-degree angulation? Yeah, there is. What you could do is if you've got some of those angle sponges and you happen to have one of those 20-degree angle sponges, the 20-degree angle is pretty shallow. It's only about like that, right? But if you took your image receptor and you laid your image receptor on that 20-degree sponge, then your hand's going to be at 20 degrees and you can use a perpendicular central ray. Both accomplish the same thing. Now, if you need to incorporate the ulnar deviation, then that would work as well, right?
So you would put the sponge under the image receptor?
Yeah, put the sponge under the image receptor. That way, if there's anything on the image receptor that would cast an artifact, it's a non-issue. Okay, so carpal tunnel, carpal canal, Trina's going to get to next year. Let's take a look at the wrist, hand and wrist views. So individual fingers, you want to see from the metacarpal all the way to the tip of the finger. You want to see the soft tissue because the patient can't have soft tissue damage that the doc's interested in seeing. So lateral, notice that the bones, the appearance of the bone becomes much more convex anteriorly and slightly concave posteriorly. And that's how you visualize whether or not you got a good lateral. Got a little bit of rotation here, but it's not all that bad. But you see the nice clear joint space. That's just an ugly image, but it's oblique, and what you see is the posterior side becomes pretty flat, as opposed to the AP. You see on the AP, you've got, it's kind of hourglass shaped. On the oblique, you lose that hourglass shape on one side, and it increases on the opposite. So it gets really pretty flat on the posterior side, and the concavity increases on the anterior side. So thumb, remember the thumb, this is pisiform, by the way, just this little pebble looking bone way out here. So remember the thumb, AP projection, only digit, we routinely shoot AP projection. It's the only digit that we include the entire metacarpal. So you gotta get all that soft tissue out of the way. Otherwise, and that's one of the small sesamoid bones right here that we talked about before. So lateral of the thumb, again, we got some sesamoid bones or possibly some chips there, but it just looks like accessory sesamoid bone. But make sure you again get all the way down to the carpal metacarpal joint space, because remember we only have two phalanges in the thumb. So if you got three, then that means you got the entire metacarpal. Oblique, pretty unremarkable. PA of the hand, nice PA of the hand. Just make sure that you don't neglect the thumb. Make sure you include the distal portion of the radius and the ulna. So two different obliques. This might be a little bit more of a PA than an oblique. It might be under rotated, but you can see the joint space is open here as opposed to over here. You see the way you don't see the joint spaces. They use the fingers as props over here. And over here they use the fingers extended. But it didn't really matter so much over here. What they were looking for is that fracture right there. So lateral and extension, you can actually see the sesamoid bones there. Again, make sure that you don't put the thumb, but you see the foreign bodies much better in the lateral hand with the hand in extension, as opposed to the lateral fan, which show you the fractures in the individual digits. So foreign bodies, finger fractures. Wrist, there's your scaphoid right there. You see the way it's superimposed by the bones around it, especially the capitate on the medial side. So on the lateral, a good indication that you've got a good lateral is, again, you got pisiform right there, and what you've got is the hook of hamate right here. And you got superimposition, good superimposition. Oblique of the wrist, 45 degrees. And oblique of the wrist, you'll see questions. You're going to have a tendency to confuse medial and lateral on this as well. The oblique of the wrist shows the scaphoid. This is the distal end of the scaphoid without foreshortening. So you'll run into questions that say that the oblique of the wrist show the bones on, is this the medial or the lateral side of the wrist?
Lateral?
Lateral side of the wrist, because we're going back to anatomical position, right? So even though the lateral side of the wrist on the oblique is elevated, and we lose sharpness, recorded detail, we get magnification and all that, it still shows us the scaphoid specifically is what the oblique shows us better than anything else, is the scaphoid, okay? So it shows us the bones on the lateral side of the wrist, but especially the scaphoid. Ulnar deviation, you see how you've got less superimposition. You can see the bone all the way around almost, right? But again, the distal portion of the scaphoid is still at a bit of an angulation, and that's what we use the Stetcher method for. The Stetcher method is either 20-degree elevation of the image receptor, or 20 degrees cephalic angulation of the central ray, so that the central ray is more perpendicular to the distal end of it, so we can see some fractures across here. In practice, you're probably going to be doing both that and that. Okay? Any questions? That is carpal canal. It makes for a cool x-ray. But they've got so many, different tests for carpal tunnel now that, I'd give you any guesses how many of these I've shot in my entire career? None, not one, not a single one. And you probably won't either. We still got it covered. So, all right, well, that's all we're doing today. And I'll see y'all Wednesday or Friday, depending on.
I do have a question about the
Sure.
physics test. So for the Friday class, are we having our test on Wednesday, or are we having it
No.
on Friday?
No, everybody's gonna be here on Friday. We're gonna divide in between, this room and I think it's 217. And, I'm not gonna be here Friday. So Trina is gonna give in one room and I'm gonna get Goldie over here to give in another room. So, bring your, Bouchon, and you can use Bouchon, just to look up answers. And, you could use your notebook, but, as far as reporting off the test or notes or anything like that, you just use that to look up any questions you have. And if there's anything that you don't get, if you can't find it in the book or in your notes, whatever, then, just, I'll open up a discussion, we'll talk about it next week.
So we're still gonna have class, you're just not gonna be here?
I'm not gonna be here, no. Yeah. So, Trina will give the test in one room and Goldie will give the test.